Hi, everybody. Welcome. We're going to give folks just a couple minutes, and then we'll get started. All right, so it's 12:31. Why don't we get started? It's nice to see everyone. Thanks for joining us for Lunch and Learn. John Snyder is out today, so I'll be doing my best impression of him. Really excited for our speaker today. Dr. Sam Bhatt is joining us to talk about some pitfalls in ENT diagnosis, part 1, otology. And before we give Sam the mic, just a couple of slides to go through. So Sam, if you don't mind just moving the slide forward. So a couple of upcoming Lunch and Learns we have for the next 3 weeks, 3 really exciting talks. The next 2 weeks are dermatology based. We have Outdam Spot, Dr. Lynn Baden and Daihung Do. And then rashes went to refer by Dr. Sarah Snyder-Phillips the following week. And then Dr. Bhatt will be coming back on October 7th for part 2 of the Pitfalls in ENT Diagnosis Rhinology. Next slide, please. And Dr. Snyder wanted me to plug our great orthopedic walk-in. I think hopefully everyone knows about our walk-in center by now, but we're over at 978 Worcester Street. We've been very busy, and we're anticipating it getting busier as people get back into team sports on the weekends. Just a reminder, an appointment is not needed. People can walk in. Someone sprains their ankle on the field, go head over. And they're open during the week, 8 to 8, and Saturday and Sunday from 8 to 1. And X-ray is on site, casting, bracing, etc. So next slide, please. Also wanted to just give a shout out to our new thyroid biopsy clinic. This is a very exciting new multidisciplinary clinic with endocrine, surgery, cytology, and radiology all in one location. So the idea is to really set up a nice little sort of service line around thyroid biopsy. You can see the criteria there for referring. Best way to refer is through Epic, and it's ambulatory referral to NWH Thyroid Biopsy Clinic. You can see the phone number below and email as well. Next slide, please. All right, so I'm going to pass it back over to Sam. So Sam, we're really happy to have you join us today. Sam is over at Mass Eye and Ear Group at Newton-Wellesley Otolaryngology, where he is the chair of ENT. So Sam, I'm going to pass it off to you.
Great. All right, thanks so much, Jeff. Hi, everyone, and thanks for having me today. Just one quick word on that thyroid biopsy clinic. So that's Dr. Perengi's baby, and we've been involved as well from an otolaryngology standpoint. I think it's going to be a really great thing for the hospital. So our topic today is diagnostic pitfalls in otology. And first, I just wanted to introduce the division. So, who is in the division of otolaryngology at Newton-Wellesley? So when I came here 7 years ago, we had 6 members. Since then, we've had substantial growth, and we're now up to 12 providers clustered in 3 groups. So I wanted to introduce the Mass Eye and Ear Group, which I'm part of, and you've probably interacted with many of us, but maybe didn't realize that we're actually all on the same team. Our growth has been designed to cover all areas of ENT in depth, including subspecialists in otology, plastics, head and neck oncology, and pediatrics, and to do everything here at Newton-Wellesley whenever possible. So I would wager that there are very few hospitals in the country that are our size who can make that claim in terms of depth and breadth. We're all based here at Newton-Wellesley, and we're always happy to take your phone calls or emails, and of course, any messages by Epic. So on to our talk today. Most lecturers tell you how to make a particular diagnosis. I wanted to do something a little different today. So instead, we're going to talk about how not to make the wrong diagnosis. And by that, I mean how to avoid missing less common but important problems that might look like or masquerade as common diagnoses in ENT. So really, this is more of an advanced lecture for experienced providers. So to avoid pitfalls in otology, we're going to review common diagnoses for the outer, middle, and inner ear, ones that you're probably familiar with. Then we'll review the important look-alike diagnoses, and at each point, we'll review the key differences between the common diagnosis and the look-alike, and then list the red flags so that if you see them, you'll know that that patient needs extra attention. So these are the diagnoses we're going to cover today. So I have it broken down by outer, middle, and inner ear. The common diagnoses are, as listed, otitis externa, otitis media, and then within the inner ear, presbycusis, BPPV, and tinnitus. In the next column are the look-alike diagnoses that we'll cover that we want to learn how to identify well. And in the right column, it shows why making the right diagnosis is important, because bad things can happen if we don't. And finally, I want to mention that except for the first one, these are diagnoses that the look-alike diagnoses are ones that I see in my practice on a regular basis. So they really do happen. So starting with the outer ear, the most common condition is acute otitis externa, which is essentially cellulitis, but of the skin of the ear canal. It tends to be caused by minor trauma, such as swimming or Q-tip use, although the patient doesn't always recall the history. And it leads then to a superinfection with the bacteria that normally live in the ear canal. This is usually, as I say, a minor trauma history, and like all cellulitis, you'll note pain and swelling and redness of the ear canal. And in otitis externa, the pain can actually progress to become very severe. You'll see a swollen canal with discharge. Pathognomonic for this condition is motion tenderness of the tragus being this little thing in front of the ear canal. And that is always tender in acute otitis externa and very few other conditions. Treatment, as you know, is topical therapy with ear drops, typically TID for 10 days. We place a wick if we need to get the eardrops to penetrate the canal and avoid water exposure and Q-tips, and typically improvement will begin within 24 to 48 hours. So what are the lookalikes for this condition? So the first is necrotizing otitis externa, which used to be called malignant otitis externa, but it's not a cancer. It's actually a type of acute otitis externa that occurs in patients with immunocompromise. The degree of immunocompromise that sets people up for this, however, can be quite mild. For example, it could just be type 2 diabetes. While many immunocompromised patients who get this will just get regular old otitis externa, sometimes it can progress, becoming skull-base osteomyelitis. And in those patients, they need aggressive IV therapy and possibly even OR debridement. And in the worst cases, it can be fatal. So that's why we're discussing it. The second category of lookalikes for otitis externa is skin lesions of the ear canal. These can be things like a small squamous or basal cell carcinoma, or even other lesions, or even a benign cyst. And these then can become secondarily infected, so the patient can present with acute otitis externa that obscures your seeing that original lesion. So what are the red flags that tell us it's not a run-of-the-mill acute otitis externa? Well, first, if the ear canal doesn't have motion tenderness of the tragus, as we discussed. Second is if there's no improvement beginning within 24 to 48 hours, especially in a patient who's immunocompromised. Third is if you see granulation tissue of the ear canal at the 6 o'clock position, meaning inferiorly. That is a pathognomonic finding for necrotizing otitis externa. Finally, if the ear canal looks asymmetric, meaning not just swollen concentrically, but then there might be a lesion in there somewhere. And those are patients you might want to send on for an ENT evaluation. So now moving on to the middle ear. The most common condition, of course, is otitis media, and this is really a continuum. So to be healthy, the middle ear, just a brief review, to be healthy, the middle ear has to be ventilated, and it gets its air up the Eustachian tube, which is located in the back of the nose, which we can see here to the right of the screen. So nasal congestion, such as a URI or allergies, causes the nasal passage to swell and the Eustachian tube to swell shut so that air can't get up to the middle ear. The normal air of the middle ear then gets resorbed but not replenished up the eustachian tube, so a vacuum can develop. And this we've all felt when we come down on an airplane, for example. If the vacuum is followed by a serous effusion, then the patient has what we call serous otitis media. And then if that becomes super infected with bacteria, of course, that's acute otitis media. So how do we make that diagnosis? Well, as you can see from above, it is really a continuum. It starts off with eustachian tube dysfunction, which the patient feels is a vacuum. Which is a vacuum, so the patient feels a blockage sensation like we all do when we come down on an airplane. And on exam, you might see some subtle retraction of the eardrum. If that space fills with an effusion, then not only will the patient have blockage, but they might actually get a conductive hearing loss, and you should see the fluid on exam, and the drum might be immobile. One handy test you can do is have the patient hum. If the patient has a conductive hearing loss, very often when they hum, the sound will go to the ear with the effusion, so it should go to the side with serous otitis media. If the fluid becomes superinfected, then there's pus. So in addition to the above symptoms, the patient will have pain and the eardrum will be inflamed, and it can even rupture, leading to discharge. Of course, as you know, if they have eustachian tube dysfunction or serous otitis media, you're going to treat with a decongestant and expectant management, and the symptoms really should resolve within 2 to 4 weeks. With acute otitis media, it's the same idea, but you treat them with antibiotics, and the pain should resolve within a day or two, but the blockage again is going to take another 2 to 4 weeks to go away. So what are the lookalikes for otitis media that we want to consider? And there are mainly two. The first is still otitis media, but one that's caused by neoplasm. And this is an important one because we do see it quite frequently. The second is sudden hearing loss. So in serous otitis media or acute otitis media caused by a mass or neoplasm, the eustachian tube is compressed by a tumor in the back of the nose, in the nasopharynx, instead of by a cold or an allergy. Examples of tumors in that location would be a lymphoma, squamous cell carcinoma, or what was often called the Cantonese cancer. So this is a neoplasm that develops in people from southern China. Benign cysts can even do it. Because there's a growth there, instead of just swelling, the effusion doesn't resolve as usual. Eventually, other symptoms from the malignancy might develop, but those tend to be pretty late in the game. So we want to make the diagnosis or have that suspicion early. So as I mentioned, I've seen a few of these just in the past couple of months. So red flags that might make you think of this. The history doesn't quite make sense. There wasn't a cold, there wasn't an allergy, there wasn't an airplane flight. Second, that the fluid is still present 4 to 6 weeks later. It hasn't shown a tendency to improve. The patient has risk factors. For example, that they're from Canton, what we used to call Canton province is now called Guangdong province, or their parents are from there, or that there are any ipsilateral signs, neck mass, nosebleed, headache. And again, those patients might need to be sent for evaluation, and we would do endoscopy to look at the nasopharynx and eustachian tube. The second lookalike diagnosis for otitis media is sudden hearing loss. And this is something we see quite a bit of, often in particular from urgent care centers. So in this condition, the patient develops the sudden onset of unilateral nerve hearing loss. It's painless, but they might have tinnitus or vertigo. It's analogous to Bell's palsy, but of hearing instead of facial motion. And we treat it like Bell's palsy with high-dose steroids that we give orally, although sometimes we give it by middle ear injections. Earlier treatment for this is better. It's more likely to be effective, and that's the reason that we want to identify these cases. It can be preceded by a cold, which can be a little misleading because that happens in otitis media too. What are the red flags that make you think of sudden hearing loss? Well, that the history is atypical. The onset of the hearing loss might be abrupt. They'll often say, I just woke up and I couldn't hear on this one side. The eardrum really should look normal. And especially if they have tinnitus or vertigo, which doesn't typically happen in otitis media. When they hum, the sound should not go to the abnormal ear. It might not go anywhere or might go to the opposite side. And that patient should get a more urgent audiogram, and if there's any evidence of nerve loss, start up on steroids. We tend to use pretty high dose. Finally, we're going to move on to the inner ear. So the most common diagnosis there is presbycusis, which of course is age-related hearing loss that's present in about 1/3 of people over the age of 65, although very often it can start before then. That's caused by a degeneration of the sensory cells of the cochlea and the auditory neurons. The diagnosis is that the patient presents with hearing loss, which is always bilateral and almost always symmetric. The hearing loss is stable or it's slowly progressive, and it's often accompanied by non-pulsatile tinnitus. It's painless and there's no vertigo, and of course the treatment is hearing aids if the loss is bad enough. So what are the lookalikes for presbycusis? The first lookalike is tumors or neurologic conditions that also impair the auditory nerves. One of the most common would be a vestibular schwannoma, which is often called an acoustic neuroma. However, it's important to keep in mind that other metastatic neoplasms or even multiple sclerosis can do this. So for example, if I see a patient who has had cancer, breast cancer, or something that might metastasize to the CNS, my suspicion is raised. So hearing loss in patients with neoplasms as the cause are going to be asymmetric or unilateral. So when you send us a patient who looks like they might have presbycusis, but we end up doing an MRI, it's likely because the hearing test showed an asymmetry. The other lookalike for presbycusis is, again, sudden hearing loss that we've already discussed. Again, the main difference there between sudden hearing loss and presbycusis is in the name. It's sudden, it's abrupt in onset. So again, the red flags for presbycusis would be hearing loss that started on one side, especially abruptly, that would be suggestive of sudden hearing loss, or hearing loss that is not symmetric. And in there, we're concerned about neoplasm or a CNS issue. Another common diagnosis for inner ear disorders would be non-pulsatile tinnitus. And of course, we see this all the time. Tinnitus is a denervation phenomenon that I say is analogous to phantom limb pain. It's degeneration of the cochlea that causes hearing loss and reduces the normal neural input to the brain that the brain is used to receiving. Because the brain no longer receives the normal neural input, it interprets the absence of that input as a sound. The same way that if I tell patients, the same way that if someone had their thumb amputated, they might say they feel like they have an itch where the thumb used to be. So the diagnosis for tinnitus, we all are familiar with. It's variable descriptions, buzzing, humming, crickets. It can be unilateral or bilateral with or without hearing loss. It's more audible and quiet. It can be intermittent, and it is made worse by stress, anxiety, depression, and caffeine, which is why we've seen so much of it during COVID. There's no easy cure for tinnitus. Hearing aids can make it better if the patient has hearing loss, and sometimes we'll recommend masking devices at night if it's keeping the patient awake. Fortunately, tinnitus in most people will abate over time, and that's a combination of the tinnitus actually getting softer and the patient finding that they habituate to it. So what are the lookalikes for non-pulsatile tinnitus? The good news is that they're the same as for presbycusis. They're neoplasms, multiple sclerosis, and so on. And the red flags, though, can be a little bit tricky. So in hearing loss, any asymmetry requires attention, as we've discussed. In tinnitus, however, asymmetry is okay as long as the hearing loss is symmetric. So the red flag for tinnitus is that if both the tinnitus and the hearing loss are asymmetric on the same side. So I'm going to go very quickly through the last condition and then open it up for questions. BPPV. I'm going to skip over how our brain interprets vertigo. And let's just talk about the symptoms of BPPV. It consists of multiple episodes of brief vertigo occurring throughout the day. Each of the attacks are very brief, less than a minute, but they can be violent. They're brought on by certain characteristic motions, rolling over in bed, lying down, sitting up first thing in the morning, tilting one's head upward, or bending over like to tie your shoes. And when it's classic, the patient does not need imaging. You treat them with the Epley maneuver, also called canal repositioning, that takes 5 minutes to do, and 70% of patients are going to get better with one treatment. However, the patient has to be symptomatic for us to give them the treatment. And regardless, it's going to self-resolve within 3 months, even if they don't get the Epley. The list of things that can look like BPPV is really long. I'm only showing you this because we want to try to decide, does the patient have BPPV or not? So how do we tell the difference? Again, BPPV's history is very classic, it's very characteristic. Brief episodes with positional change going on day after day. So a red flag is pretty much anything else. For example, vertigo that's continuous, that's not BPPV. The episodes last over a minute or two, that's not BPPV. It's going on for years. Or if they have vomiting, be concerned it's something else. So determine if it's BPPV or not. If it is, treat it with a canal repositioning maneuver. And if it doesn't seem like BPPV, or if it's going on for more than 2 weeks, consider sending them on to ENT or neurology. Also consider sending BPPV if it doesn't respond to regular treatment. So I know that was a lot to cover, but hopefully it was helpful. Thanks for all of us in the division. And again, we're always available to you if you have any questions. And so happy to take any questions that anyone might have now, and feel free to email me in the future. Finally, I am giving a talk on rhinology in a few weeks. If you like this approach, I can do this for rhinology as well, but if you'd rather I just stuck to talking about 1 or 2 diagnoses, let me know.
All right, Sam, thank you so much for that great talk. I know I learned a lot and needed to sort of brush up on some of these topics. If anyone has questions, feel free. I muted everybody, so please feel free to unmute yourself and just ask, or if you'd rather put it in the chat, you can do that as well. We have a few minutes. I have one question, Sam.
Sure.
I've had probably, I would say now, 4 to 5 patients who had COVID to varying degrees and are now coming in with tinnitus and wondering if that is related or not. And I'm not quite sure what to tell them. And if it is there anything to be done for that?
Sure. We've certainly seen a lot of tinnitus in patients with COVID, or even patients without COVID who then received the vaccine. So we're getting both questions. What I would say is this. When I reviewed the studies, it showed that the incidence of tinnitus in patients receiving the vaccine was no higher than baseline. So we have no reason to believe that the vaccine causes any permanent tinnitus, and I definitely would not withhold going ahead with the first or the second or even any booster vaccinations because of tinnitus. What may be true is that patients who have normal hearing may get tinnitus for a brief period of time, 1 or even 2 months, that may go away. Now, I've not seen publications on this. This is something anecdotal that a number of us in otolaryngology discuss. Mostly I give them reassurance, and it has occurred. Prior to the vaccine, we saw a number of patients with tinnitus, both in COVID patients and non-COVID patients. I don't think that COVID is a high risk factor for hearing loss or tinnitus. I do think that the stress everyone is experiencing, both from COVID and just from the whole pandemic, seems to be increasing tinnitus. And my analogy for patients is just like the oral surgeons say, they're seeing tons of broken teeth, we're seeing tons of tinnitus, and mostly giving patients reassurance they're doing well.
Great, thank you. Question just showed up in the chat from William Liah. Says, when I see someone with sudden unilateral hearing loss, I've been instructed to send them to Mass Eye or ER because they can get stat audiograms. Is this still the best approach, or are you and your colleagues able to see these patients quickly?
Yeah, so thanks for the question. We're never able to see them as quickly as we want to. We'd like to see them yesterday. A big problem is that we have relatively limited availability of our audio booths. They're booked out quite a ways. So I would say always consider or feel free to send us an email on Outlook or through Epic. If we can get them in at all, we absolutely will. And if we don't have availability, then of course sending them to the ER at Mass Eye is fine. I think if for whatever reason you're pretty darn sure it's sudden hearing loss, They can't hear your whispers in one ear and the ear exam is normal unless there's a contraindication. I don't see that there's any problem to starting them on prednisone at 60 a day and then getting the hearing test.
Great, thank you. One other question, and then please feel free, we do have a couple minutes if anyone has one for the chat. I was going to ask, so, we screen our Medicare patients for hearing loss as sort of part of the annual wellness visit. And what often comes up is they'll say to me, well, yeah, a little bit, but I'm not going to wear hearing aids. And it may bother them in sort of noisy situations, or that it bothers their partner more than it bothers them because the TV is too loud, et cetera. If they sort of are saying up front, I'm not going to wear hearing aids, should we be referring them to you guys, or should we just kind of check in with them annually till they're ready?
It's a good question. I think if what I try to do is get a sense of the social impairment that the person has, and very often the person will say that they don't want to wear hearing aids, while meanwhile their family and friends are telling them that this is a big problem. I think first of all, if you see someone where there's a significant amount of social impairment, or if their audiogram looks like there's a considerable hearing loss, a lot of the test is below 30 decibels, for example, that's a patient who probably is going to benefit. Modern hearing aids work well, even for subtle losses in most cases. People are different. Some patients have conditions that don't get better with hearing aids. And modern hearing aids often are very discreet. And so often we can have that discussion with the patient, and it is surprising what a high percentage of patients who initially were reluctant to consider them become very willing to consider them. On the other hand, if you have someone where it's very mild, they're really not having a major problem, and emotionally they don't seem to be ready, and particularly if they're younger, then I don't think you necessarily need to send them along, but rather maybe have them come see us in a year so that we can test them at that point.
Great, thank you. All right, last question from me, I promise, but and maybe a bit controversial for you, Sam, but I know that there are efforts to potentially sell some hearing aids over the counter, potentially, same as people can buy reading glasses, say. What are your thoughts and reactions? Is that dangerous? Do you think that's okay?
Sure.
What are your thoughts on that?
So there are two main problems with that. The first is that patients who get their own hearing aids, the way they might get their own eyeglasses, as we've just talked about, there's some lookalikes for presbycusis. And so those patients are going to miss out on being diagnosed. They don't necessarily have to see us, but I would feel much better if they saw their own physician who said, okay, yeah, you don't have sudden hearing loss, you don't have an asymmetry, it's probably presbycusis, you can go ahead. But by the way, if one of your ear keeps on getting worse, you need to come back. Because there have certainly been cases of patients who ignore it, or they get their own hearing aids and they end up having a tumor. And we don't want that, of course. Second is, I myself have gone into CVS to look and see at what kind of hearing aids are available over the counter, and they're almost laughable. I mean, they're gigantic. The quality is very poor. There are now a number of online services. Eargo is one that you may hear about. Bose has got devices out there, and some of those are good. Some of them are very solid. Costco does a reasonably good job too. I think if the person has a more severe loss or a more challenging hearing problem, or they tried those other hearing aids and it didn't work well for them, they absolutely should see someone who is skilled at it. Again, it doesn't need to be us, but it should be someone, an audiologist who's good at fitting and selling hearing aids, so that you know that at least they got a good device. Getting a device that doesn't necessarily fit them well, or is kind of one size fits all, they don't get a good assessment of whether that's right for them. The second thing, which is that we've seen a huge change in pricing structure for hearing aids. And so what you will see at a lot of places, and our own Mass Eye and Ear place included, is that pricing has been modified now so that it's much more price competitive. So the patient doesn't necessarily, I think gone are the days, at least for us, of the daunting high prices. And there's a lot of reasons for that. It has to do with how the pricing structure was made. But in any case, it can be much more affordable regardless of where they go.
Great.
Does that answer all the concerns?
Yeah, no, that's great. That's great. That's really helpful, because I think we're going to see more and more of this stuff online.
Yeah, and it's good. It makes it more accessible.
Yeah, and if nothing else, the competitive pressures are lowering prices, it sounds like. So that's good. All right, well, we are at the top of the hour. I want to thank everyone for joining, and I want to thank Dr. Bott for his great talk and for fielding questions. This will be posted on YouTube under the Newton-Wellesley Medical Group Lunch and Learn series. And again, I've done my best John Snyder impression today. I hope everyone has a great day. And for those of you who celebrate the holiday, enjoy it. All right, take care. Thanks, everyone.
Great. Thanks, everyone. Thank you, Jeff.